Today, we're going to explore overfitting through an analogy every medical professional can relate to: the difference between memorization and true understanding. Imagine two medical students preparing for their exams. One memorizes their case vignettes, word for word, while the other studies pathophysiology and learns to recognize patterns. Which student would actually succeed when they encounter real patients whose presentations don't match the textbook examples exactly? When student A encounters a real patient with slightly different lab values or an additional comorbidity, they freeze because the exact scenario isn't in their mental database. Meanwhile, student B applies the underlying principles they learned and successfully diagnoses the condition, proving that understanding beats memorization every time. What I just described isn't just a story about students. It's the exact definition of overfitting in machine learning. An overfit AI model is like that memorizing student. It performs brilliantly on the training data it's seen before, but fails when it encounters real patients with natural variations. Learning curves reveal critical insights about how well a model is actually learning versus simply memorizing data. For example, a large gap between the curves is a telltale sign that the model is memorizing specific details in the training data rather than learning generalizable patterns. In contrast, a well-performing model demonstrates that both training and validation curves converge in tandem and eventually plateau at stable performance levels. In the clinic, the consequences are severe. The memorizing student scores 99% on written exams, but struggles with actual patients and may even harm them through inappropriate decisions. Similarly, an overfit AI model achieves 99% in development, but drops to 70% in deployment, creating false confidence that leads to diagnostic errors. For medical students, memorization happens when they only study practice questions and never encounter real case variations without proper feedback. For AI models, overfitting occurs through spurious correlations, data leakage, or including features that essentially give away the answer. Just as we can spot a memorizing student by their inability to handle what-if questions or explain their reasoning, we can detect overfitting in AI by watching for warning signs. These include diverging training and validation curves, rapid accuracy spikes to near-perfect levels, dramatic performance drops on external data, and reliance on shortcut variables instead of genuine clinical patterns. The solution mirrors what works in medical education. Instead of teaching memorized answers, we must teach underlying principles and expose learners to variation. For AI, this means removing data leakage, using proper patient-level data splits, monitoring training dynamics continuously, and validating on truly external datasets. Before trusting any AI system in your clinic, demand answers to 5 critical questions. Was data split at the patient level? Were leaky features removed? What do the training curves show? How was class imbalance handled? Was there external validation? If developers can't answer these satisfactorily, the system isn't ready for clinical use, regardless of reported accuracy. Imagine a hypothetical scenario, albeit an unrealistic one. If a student always guessed healthy on a hypothetical medical diagnosis test where 95% of cases are healthy, they'd score 95% accuracy despite missing every disease. Similarly, an AI model that predicts only the majority class in imbalanced data may appear accurate but is clinically useless. It fails precisely when it matters most, overlooking critical disease cases. Medical professionals must therefore become active participants in AI evaluation. Don't be dazzled by high accuracy numbers alone, and demand to see training dynamics, learning curves, and confusion matrices with absolute values. Real medicine requires the ability to adapt and generalize to the variations every patient brings, and that applies to both human learners and AI systems. For more detailed frameworks and checklists to evaluate medical AI, please refer to my books, Diagnosing AI and AI-Assisted Medical Diagnostics, which synthesize nearly 40 peer-reviewed studies our amazing students and I published on this topic. Thank you for your attention, and I welcome your questions and collaboration in ensuring AI serves your patients safely and effectively. My name is Dr. Toma, an associate professor of algorithmic medicine at the College of Osteopathic Medicine, New York Institute of Technology.